لا لا السلام عليكم. كده طحت ولا لا؟ أنا
ما فتحت ولا ما
أعود. يلا. زين. Welcome again. Now it's the time for the third session with our moderator, Mr. Thamer Al-Nasser. Mr. Thamer is diabetic food specialist, director of Diabetes and Endocrinology Center at حائل Health Cluster, and head of the Diabetic Food Center in King Salman Specialist Hospital in حائل. Welcome, Dr. Thamer. الله يعافيك.
بسم الله والصلاة والسلام على أشرف الأنبياء المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أول شيء أنا شاكر ومقدر سعادة مدير الشؤون الصحية على هذه الدعوة الكريمة وعلى تشريفي بالحضور في هذا المؤتمر، وكذلك أشكر الدكتور مشعل النعيس رئيس اللجنة العلمية على هذه الدعوة الكريمة. بسم الله. We want to go to start today with the first presentation, inshallah, for our session with Dr. Saad Al-Batil. Dr. Saad Al-Batil, he is a consultant of family medicine in Saudi Board of Family Medicine. The presentation, it will be talking about the obesity screening in BHC. Please to welcome for Dr. Saad.
Assalamu alaikum, sabah al-khair jami'an. I would like to thank the organizing committee and the scientific committee for this tremendous scientific gathering. My talk gonna be about obesity screening in primary healthcare centers, and I have chosen this topic because if we didn't do it in primary care, who's gonna do it? So this is very crucial when we talk about healthy lifestyle. So let's start by some facts. I have nothing to disclose. I would like to just emphasize on almost 50% of our population is either over. We are talking about high percentage of overweight and obesity that impact our health and our economy and our medical services and our social life. So that percentage need to be decreased to the minimum. Now, obesity also contribute to 11% of disability, either by direct contributions or indirect contributions through the chronic disease. So we reach to a level of having the obesity as endemic in our society. Now in 2035, if we move with the same trend, almost 1 in every 2 person will be obese, and that's huge in terms of economy sequences and social life sequences. The problem is getting bigger, especially with children. Now, our young generation start to get obese and overweight, and that should ring alarm in any healthcare system, because the sequences of that in the system are going to be very hard. If you notice this figure, most of the children who is overweight or obese is middle class. Fast food is cheaper, fast food is accessible, and every single child fantasy a fast food in their meals. So it's all about a concept and how the kids and children and even the parents look at dieting for their children. Now, this is again some annual figures. An adult, the increment of obesity rate is almost 2%. And children is 3.6. And the overweight impact on GDP is 3.4%. It's minimized the GDP of any country with that rate. Now, there is a matrix to rate the country in terms of handling the obesity. And we in Saudi Arabia are 100 out of 183. So the matrix is a bit sophisticated. It's measuring the chronic disease and the reporting, and it's measuring as well the improvement of diabetes. It's measuring the type of food, and how healthy is the food. All of that taken in a big matrix, and they do the ranking. So 100 is far away from our target. We should be in the top 10. Okay, what is the recommendation? The recommendation is screening for the obesity for 18 years old and older, and provide the healthcare services for those who is positive, and doing the screening for children who is above 6 years old till 18. So screening the children is part of the mandate screening as per US Preventive Task Force and as per the Saudi recommendations. There is two tools, as you know, body mass index and weight circumference. Now, there are so many ways to do it in the primary care. Some of these body mass index scales is automated. Once it measures the weight and take the height, it calculates the body mass index. And most of the healthcare system, once you put the weight and the height, it's automatically calculate the body mass index. Now, the challenge is how to make that a mandate of the initial assessment of every single patient go to the physician. It should be embedded in our practice and embedded in DNA of the system that weight should be taken at least once per year. Waist circumference is another way to do it, but usually they do it for special cases because sometimes it's inconvenient for certain groups of patients to do it if you don't have a female nurse. Wiqaya has issued a plan for Saudi mortality rate. It's called 324 plan, 324 plans. And the philosophy behind this, for 100,000 patients, the death, it should be less than 324. Now in Saudi Arabia, we have 510 deaths per 100,000. And these death has to do with non-communicable disease, excluding the road traffic accident. Now, to reach that plan, to reach that target, you have to do a lot of initiatives. And one of these initiatives are dealing with the obesity and the sequences of obesity. Now, this is another slide from Wiqaya. As you see, Mecca has the higher rate of death. After that, Jove. What is Ha'il? Ha'il 477, better than most of the other cities in Saudi Arabia. But our target to reach less than 324. So how to do that? That challenge. Wiqaya also recommend many ways to do the initiatives, national public awareness, education for healthcare worker and education for families, enhance weight management service and primary, secondary, and tertiary cares, expand primary care obesity screening and referrals. And that's why I'm giving this talk. Okay, there is many KPIs related to this initiative. One of the most important KPIs is starting the screening for the adult and starting the screening for pediatric, for children from 6 years old and older. Now, the literature shows there is a gap in handling patient who's overweight and obese once they are positive screening. And that gaps need to be addressed properly in education among healthcare workers. I'm sure you have seen this slides many times. Now, stages of behavioral change, it goes through 5 stages. That patient who is not interested for any change, pre-contemplations, and patients who start to think about it but didn't do anything about it, and that's stage contemplations. And those patients who start to do something about it, preparation, then the action, then the maintenance, then most probably most of our patients will fall in relapse, but it's not fair because most of the patients, once they relapse once or twice, they will have the maintenance in the 3rd or the 4th cycle. So the reason I'm putting the slides to tell you it's a spiral, ongoing process. It probably wouldn't succeed from the first time, but we need to push for it. برنامج تطوير الرعاية الأولية والصحة المجتمعية في وزارة الدفاع, primary care and community health enhancement programs have done initiatives for the last 3 years. I will enlighten you about it in a nutshell, and hopefully this program can be repeated anywhere else in healthcare system, because it measures the impact of these chronic disease and obesity in our populations. They starting by standardize the 9 core services in primary care, and they put the policy and procedures, and they standardize the KPIs, and they distributed among 20 hospitals that belong to Ministry of Defense. Under these 20 hospitals, there is 44 primary healthcare centers that reporting to these hospitals. All of these centers included in this program. And they describe every KPIs. What matters to us here is body mass index, and the journey of defining a KPI is quite long journey, because you need to define it, explain it, and give examples. What you do if you have so many, what do you do if you have so few, how to calculate, how to publish your KPIs. And this is very important because you need to give your healthcare provider every single answer they have once they have the KPIs, because the difference usually it's in the interpretations. You don't want to make anything for the chance. You need to explain everything very well in the KPIs. Then the reporting starts. The reporting starting by 2022, in the last quarter of the 2022, and all of these hospitals are starting reporting. And it's amused to my eyes to see the reporting with red, yellow, orange, and green KPIs, because if you see it green from the first time, there is something wrong. So people start getting to the rule of doing the screening. And if you notice, the first KPI is measuring body mass index, second one, blood pressure, third, tobacco screening, and the fourth about diabetes. So we are talking about obesity, about chronic disease, about healthy lifestyle. This is the second reporting for 2023. Then the third reporting. This is by the end of 2023. And that's the last reporting for 2023. So it is a long kind of program that you need to sustain it by doing the business meetings. You have a representative from every department in these hospitals, and you start to meet on monthly basis. You start to answer their inquiry. We start to share the experience from each other's, and you give them the essence of urgency and how important to do this. Because most of these projects, if you didn't have a proper follow-up, it's going to fail. The plan on paper is good, but in reality, it doesn't work. So you need to have that kind of momentum and making this a change in DNA of the system. Make it embedded in the daily practice of every primary healthcare center. Now, by the end of that row, you will find a health index. And the health index is a way to eyeball the whole changes in every institutions. And it is quite complicated because there is a lot of calculations behind it, because every single KPIs has different weight, and different weight is affected by the score that you got. But by the end of the day, you have a health index. Now, this is overall view of the whole KPIs for Ministry of Defense. And we can see the trend moving from 73 at the beginning of the program to 81 by the last quarter of the last year. So if there is a will, there is a way. Home message. It's not a luxury anymore doing the screening. It's a must. We have to do it. And the screening is just telling you the magnitude and the volume of a problem. It doesn't solve it. A lot of actions need to be taken after the screening to handle this issue. It's not a responsibility of physicians. It's not a responsibility of nurses. It's our own responsibility as healthcare provider to push for the screening. Either you are a primary care, a physician, a nurse, or even a specialist. You need to deal with that. If you are a diabetologist, it's for your good interest to manage the weight of your patients. If you deal with patients with hypertension, or if you are a cardiologist, it's for your best interest to handle the weight of your patients. And the only way to do it is by doing the screening at the beginning. It's easier said than done. I know, with the busy clinic, with the lack of staff, lack of devices, with the shortage of proper resources, but always push for the screening, at least once per year. I wrote here, we must act now, but we must act yesterday. Things is getting out of our hands quickly, and you can notice that in the weight of the young generations and the impact of that in their health. Thank you.
Thank you, Dr. Saad, for a good and amazing presentation. Now, we will be welcome for Dr. Raja Raddadi. Dr. Raja, she will talk about the lifestyle medicine in the Saudi health system. Dr. Raja, Associate Professor and Consultant of Preventive Medicine and Public Health. Dr. Raja, Head of Preventive Medicine Department in King Abdulaziz University. Please to welcome for Dr. Raja.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I would like to thank the organizing committee and the scientific committee for giving me this chance to participate in this small speech. During the next 20 minutes, I will talk about lifestyle in Saudi health system. I will talk about three main areas. The burden of disease in Kingdom of Saudi Arabia, the Saudi health system transformation, and the lifestyle across the health services. Starting from the country profile, population of Saudi Arabia in 2019 is 35.7 million with the fertility rate of 1.9. This line chart shows us the population forecasting for Saudi population. As we can see here, from 1990 it was 16.4 million to 34.4 million in 2020, reaching to reduced to 33 million 2100. And this is the life expectancy. As we know, it's one of our objective in Vision 2030 to increase the life expectancy. The life expectancy for female in 2017 was about 80 years, for female 75 years. And it's expected to be in 2100 about 85 for female and 80 for males. This is also the population pyramid comparing the 3 years, the red color for 1990, the blue color for 2019, and the yellow color for 2100. As we can see here, the aging of the population become more and will become more and more, and it will be more than the pediatric age group for the aging population. This is together with other measures for burden of the disease, disability adjusted life years or years lived with disability, that's mean mortality, or years lived with disability. As we can see here in this slide, we can measure the health of the population or the impact or burden of the disease on the population by disability adjusted life years. And finally, we can say that this is the 60 years with small areas of certain disease and 10 disease disability. That means this patient or this person have 10 years of disease and this complication, and 5 years if the patient died before the expected life expectancy, which is 75 years age for Saudi population. This is an example to understand what we talk about in the next slide. So in the next slide, I will present the years lived with disability and what are the top causes of years lived with disability in Saudi population. This slide from the paper Burden of Disease in Saudi Arabia, published in 2020, the data from the global burden of the disease, it shows that in 2017, the number one top cause of years lived with disability is high body mass index, followed by high fasting blood glucose, drug use, dietary risk factor, high blood pressure, and tobacco smoke. All of these risk factors are related to lifestyle. And here also how the main non-risk factor cause death. As we can see in the red color, the first and top number one death is cardiovascular disease, and it's related to also high systolic blood pressure, high body mass index, high fasting blood glucose, and dietary risk factors. And the majority of the top 10 risk factors leading to death, disability, and disability adjusted life years are related to the factors related to lifestyle. Here is one paper published regarding the behavioral risk factors among Saudi population. As we can see here, 70% of Saudi population have low physical activity, 34%, about 44% unhealthy diet, and 12% with current smoking, and former smoker 10.6. Here is the serving consumption per day, overall consumption. As we can see here, the lowest is fruits and vegetable consumption. We are below the recommended daily consumption of 5 fruits and vegetables per day, which is one of the most important and top 10 risk factors for disease, mortality, disability, and adjusted life. Now, after we have all this country profile regarding the population, the risk factors and the chronic disease, we can start talking about the healthcare transformation and how the healthcare transformation adopts healthy lifestyle. We start here with the health impact pyramid. We can see here that the first one that predict the impact of disease and health is the socioeconomic class, followed by lifestyle. And here the social determinant of health, which is one of the top topics that we should concentrate to improve the population health, increase life expectancy, and increase quality of life. Also, the behavior contribute to 30% of the healthy outcome. And here this model shows the factors affecting health outcome when we talk about the final and ultimate goal for any health system is to reach to the health outcome by increased life expectancy and quality of life. So if the final outcome 50% life expectancy and the 50% is related to quality of life, also we can see here that health behavior contribute to 30%. It's more than the clinical care. Clinical care contribute to 20%. However, health behavior is 30%. This is about 2030 agenda for sustainable development goal. If we say the rationale for adopting this model of care, the target 3-4 is to reduce by 1/3 premature mortality from non-communicable disease by prevention, treatment, and promoting mental health and well-being. Target 3A, implement WHO tobacco treaty, and the 3.5 is to reduce harmful use of alcohol, and it's also this related to the goal of the Sustainable Development Goal. Here the guidance provided by WHO Global Non-Communicable Disease Action, the agenda from 2013 to 2020, to afford award free from avoidable burden of the disease, and this agenda updated to 2025. And the target goal for 2025 against 2010 is 25% relative reduction of premature mortality, 10% relative reduction in harmful use of alcohol, 10% relative reduction prevalence on insufficient physical activity, 25% relative reduction in raised blood pressure, 30% relative reduction prevalence of tobacco use, and half the risk of diabetes and obesity, 30% relative reduction in mean population intake of sodium, 80% availability of affordable basic technology and essential medicine related to chronic disease, and finally 50% of the eligible people receive drug therapy and counseling to prevent heart attack or stroke. And if we start with our vision, هذه من slides من الرؤية. لما نتكلم عن مجتمع حيوي, vibrant community, this slide showed in English that the vibrant community under level 1 objective to offer fulfilling a healthy life, promoting healthy lifestyle, and finally is access to healthcare and what health system can do to promote healthy lifestyle. And one of the main objectives under the vibrant society pillar is to offer fulfilling and healthy life. And when they start to explore what are the burden of the disease and what are the major problem in Saudi Arabia, they identify that unhealthy lifestyle, 75% no regular checkup, and 60% underweight or overweight or obesity. In addition to increased cost, it's also related to the treatment of non-communicable diseases, because there is increase in the chronic condition, more than 5 million chronic condition, 8 to 10 million chronic condition projected by 2030. Also premature death, this also variable is associated with non-communicable diseases. So all of these burning platforms that identified by the assessment of the current situation, they identify the importance of adopting lifestyle in our health system. Here is a new model of care. They change from hospital to home. That means the patient should look for his health during everyday work or every time at home, at work. And second one related directly to healthy lifestyle is the services shifted from treatment to prevention. And the third directly related is to change from passive recipient to active participation of the population to adopt healthy lifestyle. And here is the key objective of transformation, concentrate on key patient outcome. And as we can see here, patient-focused experience, fully integrated care, and all integrated care focused on healthy lifestyle. Patient well-being is emphasized through adequate preventive care and specialized treatment. And finally, individual and family are in control of their health by adopting healthy lifestyle. Here the population health management. When we work on the population health management, we want to reach to that more than from the population, yani we will increase from more than 21% as a healthiest population. And as long as we increase this population from the healthiest one, we will reduce the patient at risk with multiple condition. And as we can see here, usually top 5% of the patient account for 50% of the medical cost. In this model, we want to increase by adopting lifestyle the percentage of population under the healthiest part. Here is the goal to enhance the standard and quality of healthcare and services, to shift from treatment to prevention, from facility to system, from fragmentation to integration of care, and finally from passive citizen to active citizen. This is the sixth model of care. We start with Keep Me Well, that look about talking about any preventive services. Also, we can say that under the planned care, there is also lifestyle services. Under women and child health, there is preventive services in terms of with baby clinic and screening for female during pregnancy and all other preventive services. And also chronic disease. Under the chronic disease, there is a lot of screening for non-communicable diseases and adopting healthy lifestyle for the patient. Here is the final model of care. We have 6 systems of care. The corner of this system of care depend on physical well-being, mental well-being, and social well-being, with the 6 model of care mentioned. And also the model have 42 interventions that can enhance this model of care. In this slide, we can say that the 6 model of care through the patient journey through the clinical pathway include in this pathway the lifestyle, and the 6th layer identify patient services at every level of services, and also they include the healthy lifestyle and adopting lifestyle within this model. Keep Well is the one of the most popular model of care that adopt all health services. And as I mentioned, safe birth, maternal and child health include also a lot of services. Even in the urgent care, they identify any factors contribute to urgent care related to unhealthy lifestyle. Chronic disease also integration of lifestyle medicine and screening for disease and identifying the risk factors. And this is the last phase of case also of care. Even in the home health care, they start to talk about lifestyle modification among patients under home health care. هذا نموذج الرعاية بالعربي، الرعاية الوقائية. This is the first one. يرتكز على العلاج قبل الوقاية قبل العلاجية والتدخل المبكر لمنع الأمراض قبل حدوثها. وفي كل واحد من هذه ال 6 model of care يوجد داخله بعض الخدمات التي تتعلق باللايف ستايل. هنا الموديل of care intervention specified to system of care, and above is the enabler or the cross-cutting program that help to implement this care. And I try to calculate all المبادرات التي تشمل على أنظمة الرعاية وفي الموديل of care. فأنا حسبت كل اللي ممكن يكون لها علاقة في الهيلثي لايف ستايل في السيستم، فوجدت بعد عديتها كلها وقسمتها على التوتال لقيت انه 54% directly related to adopting a healthy lifestyle and providing services that promote healthy lifestyle in the new model of care. Here the wellness system of care intervention that focus on prevention, improve population willing school wellness program, also a program provided for healthy lifestyle, health coach program, workplace wellness program, community-based wellness program, healthy food promotion, and healthy entertainment, and lifestyle across the level through primordial prevention, provide prevention of emerging of any risk factors, primary prevention, pre-onset prevention, even in secondary prevention, early detection of the disease, and counsel the patient and work with the patient on healthy lifestyle. Have حتى تحت tertiary prevention, limitation of disability and prevention of death. Also, we can implement a lifestyle program. The gray color related to the community intervention for primordial prevention, as well as we can implement these services for individual patient, and the other we can remove risk factor, early detection, treatment and prevention of progression, and finally improve quality of life by reducing disability limitation or delaying complication and restoring the function. Here is the final model. As we can see here, the new model of care adopt preventive services in each level, in each intervention, and in each model of care by primary, secondary, and tertiary prevention. I tried to look for the publication on lifestyle in Saudi Arabia. I used the term Saudi Arabia and lifestyle in the title or abstract, and I identified that there is about 100 publication. This publication started to increase from 2016. This is some of the paper published, newly published about lifestyle. This is one, developing an active lifestyle children, consider the Saudi Vision 2030, family point of view, and the other one, national and regional rate of chronic diseases and all-cause mortality in Saudi Arabia. This is analysis of household survey. And this is another thing that newly implement from Wiqaya. The Saudi clinical preventive guidelines depend on counseling the patient in each age group, even below 5 years of age. Counsel the mother to learn how to make her child adopting healthy lifestyle. For adolescent, for young adult, and even for geriatric, there is areas to work on implementation of the lifestyle program in the health system. Also, in Saudi Commission for Health Specialty, we have a lifestyle fellowship under Preventive Medicine Board. There is a Sahha platform. There is also instruction about a healthy lifestyle. And finally, before I say thank you, I can say a lifestyle change begin with a vision and single step. Thank you very much.
Thank you, Dr. Raja, for your presentation. And we want to go back for the behavior risk in the discussion, inshallah. The next speaker, inshallah, will be Dr. Marwa Mahmoud. Dr. Marwa Mahmoud, she will talk about the obesity pathway and lifestyle medicine. Dr. Marwa, co-chair of National Network of the Chronic Care Expert and Hail Cluster. Dr. Marwa, she has the International Board of Lifestyle Medicine. Please to welcome Dr. Marwa.
Assalamu alaikum wa rahmatullahi wa barakatuh. Before I start, I want to thank the organizing and scientific committee for the invitation. It's such a pleasure to be among you today. Today, I will talk about the obesity pathway. And before I talk about the obesity pathway, I want to highlight what is the chronic system of care and the aim of the chronic system of care. So, as my colleague talked previously, this is the new model of care, and the chronic system of care is one of the 6 systems of care under the umbrella of the new model of care. It's concerned by empower the patient to deal with their chronic condition, and this is done by improve the quality of provided services through 3 main pillars, and which are increase and enhance the screening and early detection of chronic disease. The second one is activating the role of case coordinator among all the healthcare facilities. And the last one is enhance the continuity of care services to improve the control level and decrease the complication and mortality rate by chronic disease. New obesity pathway. I will take through the journey of designing implementation a pathway under the umbrella of chronic system of care. So regarding the obesity pathway,
And before we design any pathway, we ask ourselves two important questions. The first one is why this particular disease? And second one, what is that disease? So why obesity? As mentioned before, the obesity at the top among the lists regarding the three triage. Obesity have high prevalence rate in Saudi Arabia. Also, it placed as a second level after hypertension regarding the death rates and is estimated by 28,000 deaths during 2019. Also, you can see it represents about the fifth of total deaths in Saudi Arabia. And the last one among this triage is continuous improvement and progression of economic cost of obesity. It's expected to reach $145 billion in 2060. So this is why obesity. The second question is, what is obesity? So all of us know the WHO stated that obesity is a chronic disease or a complex disease defined by excessive deposition of fat, and that can impair the health. But obesity is not only that definition. Obesity is much more beyond that definition. Obesity is considered as a silent killer. Why is it a silent killer? And I will quote what Dr. Hassan Mwafi said in his session at the first day. If you want to know the complication of obesity, you just need to look at the index of the internal medicine textbook. So the complication of obesity take you from head to toe. And unfortunately, it may take many years before its damage is fully evident. So now we know why and what is obesity. So did we take any actions regarding that? Yes. We have designed and implemented the new obesity pathway, which is concerned by enhance the quality of provided services for obese and overweight patients. The journey of developing pathway passed through multiple steps, starting from team formation, and then we choose the best, most updated guideline. Then we have the current situation analysis and assessment of the readiness of healthcare facilities and closing the gap by providing the required infrastructure and teams. Then we designed the future state of pathway and setting a KPI list enable us to monitor and improve the provided healthcare services. This is what the pathway looks like. So if you see here, this is the levels of care, starting from the community level and end by the tertiary level of care. And at the horizontal line above, are the main steps during the patient journey, starting from screening at the first contact and ending by the treatment and follow-up. So if I take you in a journey, a patient journey, in obesity pathway. So we have starting point at the community level by community awareness, intervention, and screening campaign, and we have conducted many of community awareness, intervention, and screening campaign. This is in collaboration with another system of care, which is Keep Well system of care. And patients who have BMI over 25 will be referred to the second level, and which is primary healthcare level, where we have another starting point, so we can screening all the visitors attending the BHCs directly and also who have PMI over than 25 will pass through the completeness of assessment and management protocol. So the first step here is to assess the readiness of change to those patients. And we will talk on the next slide why we need to assess the readiness of change. The patients who are ready to change and willing to change will be enrolled in obesity pathway and continue their journey. Their journey after that will continue for assessment, comprehensive assessment. It includes physical and laboratory assessment to decide which type of obesity they have and if they have any comorbidities or complication of obesity. And the patient who have PMI after 40 or the patient who suffer from any complication or comorbidities will be eligible to refer to the other levels of care as needed. And the patients who are not will continue their management plan inside the PHCs. So the physician develop the care plan, which include internal referral to other clinics or subspecialty as health coach. Once the patient achieves the goal, during a 6-month period, the patient continue the follow-up visit either physically or through the virtual care inside the PHC. The second level of care is Essential Plus. And Essential Plus are primary health care centers, but they have an advanced services, such as we have specialized clinic as internal medicine clinic, GS, general surgery, pediatrician, we have dietitian, and health coach clinic. So the next level is Essential Plus, and this level where the patient assessed by multidisciplinary team, as I mentioned, and if the patient starts achieving the goal within 3 months, the patient will continue his journey for 6 to 12 months for follow-up and then referred back to primary health care when this patient is controlled. The last level is secondary or tertiary care, and the patient comes with acute complication directed to ER where they enroll to emergency care pathway, or the patient eligible for bariatric surgery will be directed to bariatric surgery OPD where they assessed, done the bariatric surgery, and after discharge they will refer back either to Essential Plus, to GS, or after that to primary health care to continue their follow-up visits. So we have started a new services at primary health care, and which are health coach clinic and dietitian clinic. So up to this moment, we have 31 health coach clinic, and this represents about 30% of our PHCs in higher region. And we have dietitian clinic at 3 Essential Plus PHCs, which are of total 5 Essential Plus PHCs. So what is the role of health coach? As we said before, we have to assess the readiness of those patients to change. And this is the role of health coach. So health coach has training program. They have many skills, starting from building a rapport with the patient, use the trans-theoretical model of change and assess the level of change from pre-contemplation up to the maintenance level, and they are capable to deal with the relapse that may occur at any level of change. They know how to empower those patients and set up their own plan, and this is the core of the new model of care. We have to empower our patient. We have to learn them how to be an active part during their management protocol. They use many tools, and they know how to deal with number of the productive thinking and how to enable the patient to assess the risk factor, the resistance factor, and how to deal properly with them and overcome them to achieve their goal. They also work crossover the all 6 pillars of lifestyle medicine regarding assessments and nutritional status, physical activity, mental status, social factor of the patient. It's not about the amount of information we have. All of us know a lot of information regarding obesity, the diet regimens, the benefit of physical activity as a patient or as a healthcare provider. As unless we change our mindsets, it will never work. So if I ask you, if we have 2 patients, one of them measured his blood pressure and he found it's 160/100. And the other measured his BMI and he found that his BMI 31. Which one of them will run to his physician to assess his situation? The hypertensive patient. We doesn't take the obesity seriously. Our perspective to obesity needs to be changed. And also for the healthcare provider, over many years, we're providing health education messages to our patients. And although the prevalence of obesity keeping increase over time, so it's not only one-man job. And we provide the patient what we want, not what he is need. So we need to change our strategy with dealing with those patients. It's multidisciplinary team approach, and we need to assess what they really want, what their hidden agenda, what is the risk, and we need to figure out what can motivate them to achieve their goals. So if you're practicing healthy thoughts and thinking good of yourself and others around you, then you are more likely to believe in the best version of yourself. And this will lead you to having a healthy choice, and this will be happen if you adopt a healthy lifestyle. So what we have after implementation of our pathway in PHCs? The implementation was carried out over steps, start from pilot stage up to full expansion stage to cover all our 109 PHC. And as I said, we have now 31 health coach clinic and 3 dietitian clinic inside our PHC. Over the past 2 years, we have screened 130,000 adult persons for obesity and overweight, and we have screening about 70,000 pediatric and adolescents. For adults, it represents 26% of the target population, and for children and adolescents, it represents about 31% of the targeted population. Among the screened population, we found that for adults, about 21 of them belong to obese category, and about 33% are overweight. For children, about 9% of them are obese, and 19% of them are overweight. About 5,500 patients enrolled in each health coach or dietitian clinic, and over 6 months period, 16% of them achieved to reduce their weight about 5 to 10% of the initial weight. But is it only about weight reduction? We need to make and enable our patient to see the whole picture. Weight reduction is one among many achievements that patient can get. Improve the quality of life is one achievement. To improve the obesity-associated risk factor is an achievement. To prevent complication is achievement. To prevent further weight gain is an achievement. So it is not only about weight reduction. It's about adopting a healthy lifestyle. And finally, I want to take this vote, which tell us those who think they don't have time for healthy lifestyle will sooner or later have to find time for illnesses. Thank you so much.
Thank you, Dr. Marwa. Thank you so much for your good presentation. The last presentation for our session with Dr. Maha Al-Rashidi. Dr. Maha Al-Rashidi, she is a consultant of family medicine, trainer in family medicine academic in Hail, and Dr. Maha, she is a Sibahi survey. She will talk about the bariatric diet. Please to welcome for Dr. Maha.
لا ما في مشكلة حقرأ إذا تردها. Good afternoon, everyone. First of all, I would like to thank the organizing and scientific committee for inviting me to participate in this amazing international conference. واضح صوتي. Okay, today inshallah we will talk about the bariatric surgery diet. Okay, as we all know that obesity is a chronic disease that requires ongoing effort and permanent lifestyle change. Bariatric surgery is not a cure, nor is it to be considered one and done approach to treating obesity. Weight loss surgery is simply a tool to help you to achieve healthier weight and lifestyle. In order to have a successful long-term outcome, it is necessary to make a number of permanent lifestyle changing eating habits, behavior, mindset, stress management strategy, physical activity, while the nutritional plan is one of the most important parts of this journey, but it is not the only component to success. Establishing healthy self-care habit is the key. Then, as we all know that the goals of the bariatric diet is to promote weight loss and prevent weight regain, ensure adequate nutrition, and minimize the risk of nutrient deficiencies. Establishing healthy eating habits for a long-term health and wellness. How does weight loss occur after bariatric surgery? As we all know that reduced stomach size, the size of the stomach is about 3 ounces, or the size of an egg after gastric bypass, or small banana after sleeve gastrectomy. Only a small amount of food or liquid can fit into the stomach, which will limit the daily calorie intake. A typical meal size shortly after the surgery may be 2 tablespoons to quarter cup. About 1 year after the surgery, typical meal size will be 1 to 1.5 cup. Vitamin and minerals and nutritional absorption. The smaller the stomach size, decrease in the stomach acid, and the smaller portion size will reduce the body ability to absorb vitamin and the minerals. Okay, after gastric bypass, the shortening of the small intestine will further limit the absorption of the nutrients. Vitamin and minerals supplement is required for lifelong. Food intolerance. After bariatric surgery, the body may become intolerant to food with the high in sugar and high in fat. These food may cause nausea, vomiting, diarrhea, gases, bloating. Food that may have been tolerated before surgery may be less tolerated after surgery. Some people may not be able to tolerate a healthy food. Food intolerance are different for everyone. Here is the overview of the post-bariatric surgery diet. As we all know, it's classified to 5 stages. The first stage is a clear liquid diet in the first 2 days in the hospital. The second stage, it's the duration for 2 weeks for bypass and 4 weeks for sleeve gastrectomy. Stage 3 is pure diet and it's lasting for 3 weeks. Then soft diet for 2 weeks. Then the final stage is a regular bariatric diet is for a lifelong. A liquid diet, as we said, it is for the first 2 days in the hospital. It's only to have adequate hydration, can drink sugar-free, non-carbonated beverage such as water, decaf coffee, and decaf tea. Such as fat-free broths, sugar gelatin, and sugar-free popsicle. In the second day, the full liquid diet, in addition to the clear diet, we will add the non-fat milk and sugar-free protein shake. It is important to stay healthy as rapidly lose weight. Ensure to consume at least 60 grams of protein per day by drinking a protein shake 3 times per day. Then the pure diet, the duration is for the 3 weeks. Now we will start to begin consuming a solid food that have been pured to a smooth consistency. Should avoid consuming overly spicy food at this point, and should use a healthful cooking technique such as grilling, baking, stewing. Soft diet for 2 weeks, ground lean milk, flaked fish, eggs, or cottage cheese. For regular bariatric diet, now we are at the 7 weeks. We are ready to advance to regular texture and reintroduce a greater variety of food into the diet. This is the diet that should follow for the rest of the life. Should continue to focus on a protein and avoid high fat or sugar sweetened food. Eat slowly, listen to your body, and stop eating when you are full. This is the bariatric plate diet. It's high protein, low carb, and low fat. Always start with the protein, then vegetable, then starch. Okay. What is the side effect of bariatric surgery? As we all know, when that dehydration can happen, it is important to stay hydrated and drink adequate fluid every day to avoid dehydration. Nausea and vomiting, it's caused because of eating too fast, eating too much, and drinking fluid during the meal. Okay, to avoid this, we should practice fluid window. Do not drink fluid 30 minutes before eating, while eating, and wait 30 minutes after eating. As we all know, in dumping syndrome, lactose intolerance, constipation, gases, heartburn, weight plateau, and weight gain. Weight plateau are normal in the first year after surgery. If your plateau lasts longer than 3 to 4 weeks, consider increasing exercise or tracking your dietary intake. Weight gain may occur after the surgery if dietary change is not made, exercise is not performed, or emotional eating habit is not addressed. Hair loss, this is temporary. It's side effect of surgery, stress of surgery, anesthesia, lack of protein, and lack of nutrient. The life cycle of the hair follicle is about 3 months. To avoid this and minimize this, take adequate protein, and multivitamin. Lifelong dietary change for successful weight loss. It's important to avoid high-calorie foods such as fried food, fast food, high-fat processed meal, dessert, sweetened beverage, and avoid the food fillers like pasta, rice, greens, and cereal. As we all know, that not only focus on diet and overlook exercise. In reality, the exercise is just as important as your diet for your long-term success. Benefit of exercise, as we all know, increase the life expectancy, burns calorie, reduces fat, weight management, lower blood glucose, improve mood and self-esteem, improve blood control and insulin, help control hunger, improve sleep, and relieve stress. As we all know that vitamin and mineral should be started before the surgery. We should take a multivitamin with iron and calcium before the surgery. And after the surgery, should introduce B12 and vitamin D. Thank you for your listening.
Thank you, Dr. Maha, for your presentation. And just I would like to call all our speakers for the session to become on the stage for open discussion. Thank you. Bismillah. First, I would like to thank all of you for the good presentation and the good information and very updated information and the numbers. The first question it will be for Dr. Marwa. Dr. Marwa, just there is a question it's asking for referral from the PHC to bariatric surgery. When it will be and what's the criteria for that?
So regarding the bariatric surgery, we have many inclusion criteria. For BMI, the inclusion criteria are if the patient has BMI above 40 without any comorbidities, or if he has BMI above 35 with comorbidities, or if he has a BMI above 30 with uncontrolled type 2 diabetes or cardiovascular disease. And if the patient has a history of failed non-surgical weight reduction trial, he is eligible for bariatric surgery. And also, we need to make sure that this patient has no history of any psychiatric disorder, especially eating disorder, or he's not suffering from active cancer. Also, he is eligible for bariatric surgery. After he referred from the PHCs to the one-stop clinic in Essential Plus, those patients goes under a comprehensive physical and laboratory assessment by multidisciplinary team, and according to the result of those investigation, the final decision is made if this patient will undergo the bariatric surgery or not.
Thank you, Dr. Marwa. Dr. Saad, we have one question for our audience. It's asked about the responsibility of education and screening of the patient and obesity in the BHC. This is a responsibility of who exactly?
Thank you for these questions. I think this is a responsibility of all. especially decision makers and leaders in primary healthcare centers and those who's making the policy, they should realize and have the proper mindset for addressing the proper assessment for the patients. It starts from the leaders and cascading to the whole healthcare teams, and should be part of the policy of assessing every single patient comes to you in primary care. Now we are talking about someone comes to you in the primary care. As a matter of fact, we need to do the screening in the community. But what we mandate right now is including the screening as a part of the assessment for every single patient that comes to you in the primary care.
Good. Thank you, Dr. Saad. Also, I have one point and just comment I would like to ask you. For the screening, as what you mentioned in your slide, you are talking about the obesity, especially for the children. What do you think the screening of the pedia and the children is starting from who and where?
Well, the recommendations is actually different. In the US Preventive Task Force, they mandate the screening, or they recommend the screening from 6 years old and above. In Saudi, recommendations is 5 years. And it's usually related to the beginning of the primary school. Those who's getting to the school need to be screened. And not only that, it need to be actually the number of minutes of exercise for children need to be 1 hour per day. It's not like 30 minutes of walking. 1 hour of vigorous or high intensity exercise in terms of walking and running and playing, and that's on daily basis. That's why there is a huge responsibility on the schools to implement such activity and make the infrastructures proper for our beloved children.
Okay, thank you, Dr. Saad. Dr. Raja, we have one question here asking about the behavior risk factor, how to be reducing and how to be correct that in our culture and our people.
Okay, good question. Related to the risk factors, as I mentioned, there is levels to provide the services, either for the whole population through policies or facilitate the presence of area for walk and easy access to healthy diet. For the school, as Dr. Saad mentioned, school programs and also workplace programs. Another way at the primary care clinic by screening for all behavioral risk factors. For us in the preventive medicine clinic, we have guidelines for each age group to counsel and screen for any behaviors or risk factors. And finally, even for the patient with the disease at secondary and tertiary level, there is implementation and looking for the risk factors to, as I mentioned, according to the level of prevention to reduce mortality, reduce complication, according to the objective of that behavior.
Right, Dr. Also, we have a second question for you, Dr. Raja. We ask about how to be served our people for the life in the lifestyle service in throwing of model of care in the health centers.
Yes. Okay. One of the model of care, the first one is the preventive. There is a lot of services inside this preventive, not all directed to the lifestyle, but the majority of this related to the lifestyles. Another way in chronic disease model of care, there is also I think Dr. Saad know a lot about that, how to deal with patients with diabetes, hypertension, dyslipidemia, and or cardiometabolic diseases, to counsel them for lifestyle, either to control the disease, to reduce complication, improve quality of life. Another way for tertiary prevention, our specialty, we have a cardiac rehabilitation clinic. There is a special nurse certified for that with the preventive medicine and cardiologist working on reduced second attack of MI. So all levels of providing services from primordial prevention to tertiary and even quaternary prevention, this model of care can apply the lifestyle medicine.
Yeah, Amazing. Thank you, Doc. Dr. Maha, we have one question for you. Just ask what the complication we cannot be happen the post-bariatric surgery if the patient didn't get the vitamin supplement.
He will have some nutritional deficiencies, such as vitamin B deficiency, vitamin D, calcium deficiency, anemia. The absorption, it will be reduced after the bariatric surgery. And we are ensure always and educate the patient about the importance of taking the multivitamins after the bariatric surgery.
Yeah, exactly. As what you mentioned in your slide, before even before the bariatric
Yes,
surgery.
we started before the iron and calcium. Then after that, we will take vitamin D and B12.
Okay, thank you, Dr. Thank you, everyone, for your good presentation and good look. And we have, inshallah, to see you in future in Hail, in another conference and another international conference. And again, we will say welcome to Hail. Thank you so much.
Thank you.
يعطيكم العافية جميعا.
Thank you, our moderator, speaker, for the informative presentation. And now the time to honoring our moderator and the speaker. Thank you, Dr. Saad Al-Battal. Thank you, Dr. Raja Al-Raddadi. Thank you, Dr. Marwa. Thank you, Dr. Maha Rashidi. And now we'll join with us Dr. Yusuf Al-Jarallah to honoring our moderator, Mr. Thamir Al-Nasser. Thank you, Dr. Thamir Al-Nasser. Thank you all. And now the time for the break for 35 minutes. لكن Assalamu alaikum. Welcome again. Now the time for the fourth and last session with our moderator, Dr. Yusuf Al-Jarallah. Dr. Yusuf Al-Jarallah, pediatric consultant, executive director of academic affairs, training and research at حائل Health Cluster. Welcome, Dr. Yusuf.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. Welcome back in the Hail International Lifestyle Medicine Conference 2024. We will continue our session today with the first speaker, Dr. Mishari Yusuf Al-Jam'ani from Saudi Arabia. He is a family medicine consultant, trainer in Hail Family Medicine Academy, executive director of New Middle Care. And he did a great effort in the new middle of care at Hail Health Cluster. Please, Dr. Mishari. Dr. Mishari, he will talk about the new middle of care.
Assalamu alaikum. Good afternoon, everybody. I am happy to be with you and have these opportunities to introducing the new model of care and what we applied here in Hail, especially in Hail Health Cluster. So why a new model of care? The vision or National Vision 2030, it aims to focusing on the health value by healthcare services outcome over the cost. What's aim from our strategic aim to increase the life expectancy from 74 years to 80 years, and how we can reach this by decreasing the deaths from the 4 main causes of death in Saudi Arabia. We have a cardiovascular disease, we will decrease the deaths by 40%, and the diabetes and kidney disease, respiratory by 70%, and also the maternal and neonatal by decreasing by 70%. What's the difference from the old model of care and new model of care? Actually, the old model of care, we have our people surrounded by a lot of facilities, primary, secondary, tertiary, private sector, but he's confused and he didn't know how to reach to these facilities and get a benefit from it. In the new model of care, our aims to focus on our people by empowering them, have active people, and all these 6 systems concentrate and focus on our people, and we have a 6 layer of services. Before the old model, we have primary, secondary, tertiary care. Now we have a 6, starting by active person and healthy communities and virtual care. This is, as Dr. Raja mentioned before, this is the aim. We will transfer these services from the hospital to be introducing in the home by the virtual clinic and by the home care services. And from activities, we have a lot of activities, but the outcome, it's a little bit comparing about the activities. From the treatment to prevention, and also from institution to be integrated system together. And from physical building, we will work on the virtual services. We can reach in our services the peripheral area and specialized care by easy access. From fragmented, every facilities work by themselves, to integrated together in the good or clear pathways. From passive recipients to active participants, and this is our aim on the lifestyle medicine, to engage our people to be aware in their health and have a good and healthy societies. As you see here, we have a 6 system of care and 6 layer, as we mentioned. The 6 system starting by the keep well system. After that, planned care system, safe birth system, and urgent care, and chronic care system, and last phase, or call it now, palliative care system. This is the 6 enables that we can apply by it our new model of care. They will be a purchase program and sector governance, and also participating of the private and third sector, uses of the electronic health programs, and empowering the workforce. For example, like Meccan program for empowering our workforce in our facilities. We see here each of these systems can work with our peoples, starting by the keep well. This system focusing on stay well and get well again, by empowering a lot of pathways and interventions. We can see here also for the chronic disease, also we will focusing on the chronic condition, and we have a lot of the pathways, around 16 pathways, focusing just on the chronic system. Each one of them have a target. For the keep well, to prevent the disease and have lifestyle medicine applied to our communities, especially by have this intervention. As we see here, from our national targeted for the new model of care, we have 42 intervention. 15 of them is on the national levels, like the health research program, system data collection, and also health in all policies, and also health hotlines, and enhanced primary care services. The others interventions, it's be multiplied on the 6 systems of care. We'll focus on the keep well and the chronic. We had a lot of disease, and we have a lot of people, they didn't know about the disease, so we're starting our chronic screening program in Hail, in the primary care facilities. We reach around 330,000 of our population to have screened now and enter our program in Hail. And we activate the case coordination, because we need the continuity of care and have to our patient go from each levels of services by the case coordinator, from primary and secondary and tertiary. And continuity of care services by have multi teams follow up our patient from the team-based care in our primary care, and specialized center, and also virtual clinic, and advanced clinic. For the people, we will start a program. It's called Health Coach Program. We reach around 33 clinics now in Hail, and we train them according to lifestyle 6 pillars to be good with their patients in the primary health care and follow up well. We're reaching around 4,500 patients with this and with their health coaches. Also, we should to have the community-based wellness program. After that, we have a school wellness program and healthy food promotion. I'm promoting the Saudi CDC. This is the big program and in the national level. So we reach from each of these systems, we have a pathways. We reach 42 pathways. Each of these pathways have a clear pathway from the society to reach the tertiary center or hospitals and came back again to the society and the primary care. This is our vision for our cities. The goal to enhance standard and quality for healthcare services. The public sector will focus on its planning, regulatory, and supervision. And the public sector will depend collaboration and integration between health and social care. Dr. Raja already mentioned about target. We will, inshallah, work on the prevention either than treatment, working as a system, not alone facilities, working integration, not fragmentation, and we should focus, especially in our lifestyle medicine, on active citizen, not passive citizen. Thank you.
Thank you, Dr. Mishari, for a clear and nice presentation. I would like to remind our audience to sharing us in the question and evaluation of our speaker according to the barcode. Now with the second speaker in this session, Dr. Abdurrahman Al-Dargawi from Algeria. He's epidemiologist and biostatistician, serving as a BHM director and clinical excellence lead at Hail Health Cluster. Currently, he is a member of National Population Health Management Expert Group. He specializes in integrating value-based care and lifestyle medicine into population health strategies. Dr. Abdurrahman is also one of the excellent member of research committee in this conference. He will talk about population health management journey towards value-based care. Please, Dr. Abdurrahman.
السلام عليكم ورحمة الله تعالى وبركاته. بسم الله والصلاة والسلام على رسول الله. So I am thrilled to be here, and I thank you for having me as a speaker and giving me the opportunity to be part of the scientific committee. So thank you very much for that. So Hail Health Cluster, Population Health Management Journey Toward Value-Based Healthcare. So a little bit of context. So the Vision 2030 aim to create a vibrant society. So we are witnessing this huge project taking place before us. But for what and for whom? So we are building this project with people and for people. So we need for those projects to have healthy people to build them and healthy people to enjoy them. So first we need to ask ourselves this simple question, but a very important question. Why we are doing all this? Why we are investing in this huge transformation in healthcare? So the response or the answer are here. We have an increasing disease burden, especially chronic disease. We have a low financial sustainability. There is no correlation between the reals invested in healthcare and the quality of care. We have an inadequate quality and safety of care, limited access to services, and limited digital maturity. So we have a lot of systems running in حائل Health Cluster, but no one can, for example, answer the simple question, what are, for example, the prevalence of obesity or prevalence of diabetes? And we are working on that. So here in حائل Health Cluster, we believe in population health, and we believe in value-based healthcare. And it is well expressed in our حائل Cluster strategy, which is built around these 4 items, which the first one is improving population health and reinforce prevention. So the aim of healthcare is, of course, patient experience or quality, population health, reducing costs, care team well-being, and health equity. We have now what we call the quintuple aim of health. But a lot of people say that we are doing all this to reduce costs. Yes, we are doing this to reduce costs, but not only that. I'd like you to consider reducing costs as not as an aim, but as a result of population health, patient experience improvement, health equity, and care team well-being. As a result, not an aim. So here, this is what we call the equation of health, or what makes us healthy. So we have behaviors, we have community environment, we have clinical care, and we have policies. So all these contribute in one way or another to our health. But what is the weight of all that? If we consider clinical care, we have 10% or 20%. 20% of clinical care is the contribution to the health equation. We have gene, 10%, physical environment, 10%, social and economic factor, 40%, and health behavior, 30%. So our strategy is to invest heavily in healthcare, we are contributing only to 10% or 20%. So now we are inviting ourselves to think differently with population health management, with lifestyle, and with improving well-being of our population. So population health is all about what happened outside of our current healthcare delivery model. It's all about what happened outside the 4 walls of the physician. And now we will make the case for that. So what are the population health management spirit? First, we invest upstream. We focus on prevention, on root cause of diseases. We make evidence-based strategy decisions based on research. We implement multiple strategies with our colleagues in حائل Health Cluster and out of حائل Health Cluster. We collaborate with different stakeholders, and I am very happy to say that we are collaborating with the PHCs, with our colleagues in the model of care, with our colleagues in statistics, and we are not working anymore in silos. We are engaging citizens, so the citizen should take his responsibility and should know that his health is his own responsibility. And this is very, very important to consider. Increasing accountability for health outcomes, that matters to the patients, not only the clinicians, that matters to the patients. What are the components of population health management? First, know your population. We cannot say that we are an accountable care organization and we do not know our population. The first thing first, we need to know our population. Identify gaps with community health need assessment. Stratify risk among our population. Engage patients and citizens and manage care, and of course, measuring outcomes. So what are the ingredients of success? First, we need people with the right culture, we need processes, and we need technologies. If we have this component, I think that population health management will succeed in حائل health cluster. So there is a big debate about what is the difference between population health management and public health. We can end it with this. So the term public health is slowly being replaced by population health, and it's a wider range. And public health, our colleagues in public health, they are doing population health, and we are doing public health. So we have a lot of commonalities. So if we consider the case, what we know for fact is 85% of health or quality of life is not about healthcare delivery. So considering this is very important. So what we are, or what makes us healthy? So 10% access to care. It means us. We are contributing 10% to the health of our society and communities. 20% genetics. And even genetics can be modified by what we call epigenetics. If we have a healthy lifestyle, we can work on the expression of our genes. 20% environment, 50% healthy behaviors or lifestyle. And what we are doing, we are investing 88% in medical services. And this is really not logical at all. We need to make a shift in our thinking and in our strategies. So we need to invest more in healthy behaviors and lifestyle. So this is the key message from this presentation. Here we show that the upper 50% of our population or sick population account for 97% of healthcare costs. So we need to keep the lower 50% healthy, and we need to put those who are in borderline into a healthier state with reversing diseases. And we need to do what we call case findings for those who are at risk. So this is what we call our virtuous, not vicious, virtuous cycle. This is our compass in population health management. First, we need to identify our population. With what? With the community health need assessment. The community health need assessment is for us as population health management, our stethoscope. So we need to do it each 2 or 3 years. Then we prioritize our interventions with the different stakeholders. And then we will implement intervention, analyze our population health management. We will hopefully do population segmentation, the full some numbers regarding right number when we finish 2 projects. The first one is the population health management that we did just before this session to train the trainer for community health need assessment. Really overview the population segmentation framework. Exercise for population registration, we included 12,296 persons. And then the community health need assessment. We did the community need health assessment survey, workability survey, windshield survey, focus groups, interviews, health forums, and secondary data reporting. And we had a great pleasure to do the focus group and interviews. And when you get to your population and you ask them questions, they will enlighten you about the health status, and they will give you the problems that needs. They will give you the answer to that. So it was really a very interesting learning moment for us as a population. Called a POC, or proof of concept of population health management. We saw in the why, the first slide, that why we are doing. We have a lack of integration platform. We can get the information from different sources and get the right number. And we succeeded in implementing this population health management platform. We included 15,000 people, and we get some number. For example, 70% of our patients were diabetes, 72% were overweight, and so on and so forth. And a lot of information pops out. For example, we saw that more than 30% of type 2 diabetes patients had depression. And this enlightened us. So we needed to tackle this problem, and we need to do something about that. So what we can do with population health management platform is endless. So this is the part of the community health need assessment and the interviews with leaders that we performed in the community health need assessment. Now let's talk a little bit about value-based healthcare. So if you look at healthcare problem, the healthcare problem remains a global issue. And if we see the healthcare spending versus GDP or income, it is skyrocketing. And we remark also that there is no or lack of correlation between what the riyals or dollars spend and the quality of health that we have. So quality versus volume. So if we say, for example, and we used to say, for example, I did this year, for example, 5,000 imputation, the successful imputation. This is the mind working. We are working volumes, but someone can say why we are or why we have imputation in the first place. This is the question: why we are having 5,000 imputation in the first place? So we need to reflect on ourselves and think quality, not volume, value, not volume. So fee for service, overutilization of services, and fragmented and uncoordinated healthcare. This is what we are doing right now and in the world. But what we are hoping to do in the future is value. What is value is the quality of patient outcomes relative to the dollar expended. As simple as that. Are rewarded for helping patients improve their health, reducing the effect of an incidence of chronic disease. I think that we need to shift our mindset to that. Provide high quality care, and high performing providers can share savings. So this we are aiming to in the future by embracing the values of value-based healthcare and population health management. So the benefits are known by everybody. What are the benefits of such a system or such a framework? But I think healthcare and population healthcare is really essential, and it is ethical to do value-based healthcare. So to begin with. So there are a lot of payment systems, but the best ones are those who are exposed to more risks. For example, capitation and bundled payment. And I think that we will have in KSA a mix of them. So bundled payment and capitation. So حائل health cluster will either share incentives or, you know, by being proactive and focusing on prevention and for healthcare. Analytical, we have a lot of struggle with numbers. We need to get them right. Care, and we have a nice example with our colleagues. We are proud, really proud of different projects, and we are thanking them for what they're doing. We know what lifestyle medicine. We need to our colleagues in PHCs and model of care. We trained the first batch in lifestyle medicine. It was a nicely experienced with our doctors, collaborating in the training of their health, our health coaches. So we are very proud of the best of our population. And addressing social determinant of health is key in population health management. This is I think, yes, this is the end of my talk. Thank you for inviting me. Thank you for being here. And see you, inshallah, next in
Thank you, Dr. Abdurrahman, for excellent presentation. I would like to remember again for our nice audience to sharing us with the question and evaluation of our speaker in this session. Now, with the last speaker, but not the least, Dr. Najat Atoum from Sudan. She is assistant professor at the Clinical Nutrition Department, College Applied Medical Science, University of Hail, registered consultant dietitian at Sudanese National Council for Medical and Health Professions, registered nutrition specialist at the Saudi Commission for Health Specialties, certified diabetes educator. She will talk about artificial intelligence in your plate, personalized nutrition, and sustainable food choices for healthier planet. And you, please, Dr. Najat.
Assalamu alaikum. Good evening, everybody. First of all, I would like to thank the organizing committee for inviting me for the second time to participate in the International Conference of Lifestyle Medicine in Hail. Today, I'm going to talk about, we can say, relatively new area in the relationship between AI and health in general, AI or artificial intelligence used in nutrition and personalized nutrition per se. So to set the floor for the presentation, we need to know what is AI. AI or artificial intelligence is a non-human mechanism that demonstrates broad range of problem solving, creativity, and adaptability. Music or symphonies, translating text. This is the general AI. The other definition is the artificial intelligence, which is the term that we use nowadays. And in some documentations, you will find that it is interchangeably used with machine learning. In this model, we can say that it resembles what we have nowadays. But it's a model, it's not a mechanism. It solves sophisticated tasks. For example, in health sector, identifying some problems using radiological images. Model, they had to feed the algorithm with thousands and millions of images from radiology, for example, in order to provide all the model. So whenever you have an image, you can feed it to that program. What's the problem there? The general artificial intelligence. Now we will talk about the relationship between AI and personalized nutrition. Traditionally, as dietitians, we used to sit with the patient, ask questions, interview the patient in order to do the assessment. All of these things, and it takes a long time. But during this process, there are some information might be missing, like style, often are overlooked, individual needs. So in order to come up with and data, lots of time to simplify it, to reduce the time using artificial intelligence, seen advertisements while you are surfing the net, going through the different social platforms, social media platforms. Some of these applications are advertised. These applications, let's say the most general one is in your phone, where it tracks your physical activity, counts your steps. In some types of applications that can help you measure your pulse, your in regard to energy and other micronutrients or macronutrients. So these models can I think you are familiar. You ask question, it will give you an answer. It helps in offering personalized dietary advice and coaching through virtual interaction. Recipe generation platforms. You can create recipe based on your individual needs and preferences and culture. Many scientists nowadays are working on using the graphics, using the camera, where you can take a picture of your food and then it will give you exactly how much nutrients and energy are in your plate. What does AI has to do with the sustainable food choices and our planet. The sustainable food choices is a challenge because when you produce food, there is a cycle. And as you can see here, that our food system involves employment, renewable energy, trade, economic growth. These are the positives. It impacts our health, culture, and animal welfare. But on the water, we have huge amount of gas emission that influence our planet, participating in the global warming. Also the waste of food and the deforestation or the plants in our forest, which also affect the planet. Or changing our dietary pattern is crucial for a healthier planet. For example, use 1 pound or 1 kilogram of meat, you will need lots of water to water the plants that are going to feed the animal that we are going to eat at the end. AI can help in identifying sustainable food options, like highlighting sourced foods, the seasonality of those foods and production, plant-based alternatives for the diet that we are consuming through apps and platforms. Reducing waste. AI is a powerful tool. IPN, the company, a tool where it can track, you put the type of the food, the barcode, from the source till it arrives at your plate, and how many kilograms or how many kilometers did to reach you, and how much energy. People are thinking that we need to consume the foods that are produced near to us or locally in order to save the planet. The other thing is that AI tools can help minimize the food waste by optimizing grocery shopping and meal planning. Globally, around 13% of food produced, significant quantities are wasted before even we buy it. Markets, an estimated 17% of total global food production is wasted in household. We don't eat it, it's spoiled in our fridges. Between 691 and 783 million people faced hunger in 2022, and this is recent. 88% of total energy usage in the global food system, and it is estimated that the cost of the food waste is around $1 trillion per year. So the supply chain, the example that I gave about IPM, is a technology powered by AI. It can track, as I said, the food and production practices, fostering sustainable choices. This is an example of how AI can help us reduce the waste, like the smart fridges. When you put the food, you scan the expiry date, the fridge will remind you that the food is about to expire. It even gives you suggestions for recipes to cook that food, what is available in your fridge, remind you that the amount or the quantity that you have is not enough and you need to buy. So there are lots of features. What about the AI? Integration with wearable technology. I'm sure devices and insulin pumps. This is an integration between two wearable devices. The watches that we use or some, all of these needs to be the provide the maximum, let's say, assessment, and care for the patients and for the population. This will help in providing and recommendations in a real time. Also, advanced recipe personalization. culturally diverse, using AI in culturally diverse and sustainable meal plans based on individual preferences and dietary restrictions. So there are many challenges and opportunities in using AI in nutrition. The challenges include data privacy and security concerns, access to technology and digital literacy, regulatory frameworks for AI use in healthcare, integration with of AI in providing healthy food and healthy diet, or healthcare in general. Recently, the WHO released a document about the ethics and governance of artificial intelligence for health, guidance on large multimodal models. This document urges protect the consumers. Lots of data, lots of information about the patients, which are considered private, and their medical history, their life, their social history. And these data should be preserved in order authority for data and artificial intelligence that covers all of these points. For AI, increase education and awareness about AI in healthcare. Us are familiar with the technology. Remember that people who are a little older, they might not be familiar with this kind of technology. So awareness and education is very important. So AI is not for everybody. I believe that the new generations, our kids, let's say 90s, 2000, all of these generations, I think it will be easier for them to use AI. Collaborative efforts to address ethical and regulatory concern is very important when fostering innovation and entrepreneurship in this field. As you are doing what they are doing, the organizers are doing in this conference, like organizing hackathons and all of these kinds of activities. So collaboration is the key, where researchers need to develop for responsible need to integrate AI tools into their practices and education applications. With that, I would like to conclude that AI is very important. It's a very helpful tool. Whether we liked it or not, it's integrated in our smartphone nowadays. You can see that in your computer, you have, in the update, you have Copilot. We have ChatGPT nowadays. We have Gemini. We have different kinds of AI tools. Even my students at the university, sometimes they bring assignments generated by AI. But this is something that we need to think about. And embracing AI is very important. We have to think that it's not going to replace human minds. Human minds created AI. It's vice versa. If I'm going to tell the AI that I'm originally from Sudan but living in Saudi Arabia, suggest meal plans and recipes for me, it will generate it. But it will not take with that my experiences, my culture, my emotions, which is very hard for AI to read. We use our mind, our hearts, our emotions to read the person in front of us, to interact in front of us, will never be
is committed to time. Now I invite Dr. Mishal Abdurrahman Dargawi for the stage to receive some question.
You
so much for really. I'm lucky moderator because all of you finish on time. So that and also I think inshallah this information easily you get it. We have some question from our audience. The first question for you, Dr. Mashari, this is from one of our audience. Where you apply the clinical pathway at حائل Health Cluster?
Dr. Yusuf, we have already 109 primary health care center and 15 hospitals. For each pathways, we have applying on that side for the chronic disease and safe birth, and also for the keep well, we applying most of them in the primary health care, and for the urgent care also we have central hospital here by transfer and have a line contacting directly with them.
Okay. This is from one of audience. You mentioned in your presentation there is a 20% of genetic predisposition for the health population. Is there any way to decrease this percentage?
Thank you for your question. You said you are lucky for having us. We are privileged to having you as a moderator for our session. For the question, I said it already. We have what we call the epigenetics, and we say that genetics is not a fatality anymore. So if we work on lifestyle, behaviors, we can change the expression of our genes and alleviate a lot of chronic disease. So we have something to do, even with our genetics. It's not a fatality. We can do something about that. And that's really amazing to consider and to ponder upon.
Okay. Dr. Najat, there is a question also. You mentioned about the artificial intelligence. Is there any rule to minimize the incidence of the food poisoning?
I think the tracking mechanism of the food from where it comes, the source of the food, and how long it spends in order to reach us. The food can spoil during transportation or during production process, transportation, processing, and then cooking, and then preserving these foods or keeping it, for example, in hot or cold places. The tracking mechanism is very important. Is empowering consumers, like, for example, the example of the fridge, the smart fridge, where the fridge can tell you if the food is about to expire or not. So you will avoid using that and avoid the crisis, for example, of food poisoning.
Okay. Second question for you, Dr. Mashari. This is from one of our audience. He's asking about what is the common disease with the new model of care. Now the incidence is decreased.
We have work with our HM also for this. Working with the control.
Population health. So we have Lotion himself. So we need to apply more techniques like coaching. So the healthcare provider coach, because the solution is in the mind of our patients, not in our healthcare provider. We need to use, for example, what we call motivational interviewing to empower people to do the change and to change themselves. We can utilize also the AI, wearable devices, to interact directly with our patients. And we are doing that health cluster. So we can apply a lot of strategy to engage the citizen. And at the end of the day, we need to have a responsible citizen that knows that his health is in his hand. Okay. This is the
Dr. Najat, this is one of our audience asking about artificial intelligence. Mm-hmm. What is the artificial intelligence impact on the children? And how will be affected the health of the children?
Actually, my son is here with me. We came from the school directly to here, and he asked me, I told him that I'm going to present, and I had to explain what's the meaning of conference and speakers. And I told him that I'm going to talk about AI. And immediately he said, are you going to bring a robot with you? So they are, when they are using these computers and even watching TV, they know that AI is there. For example, when they are watching, for example, on YouTube, you watch one segment and then the algorithm will suggest something similar. When you talk about something and you didn't deactivate in your mobile phone that part of I think audio recognition or something like that, it will listen to you. And when you open your mobile, for example, on X platform or whatever, you will find that, let's say that you were talking about a car. Immediately you will see advertisements about cars, because there is, in the phone, you can deactivate that part or that mechanism. So I think the load on us is much bigger nowadays, educators and schools, to teach the children about the benefits of AI and how we can use it for the good and how to avoid the bad. The inventions like car was good, sometimes car is bad because it causes accidents. Knife is good, we use it to prepare to cut the food. At the same time, while I'm preparing the food, it might cut my hand. So pros and cons of artificial intelligence should be clear to parents, children, educators, community, in order to avoid, let's say, side effects of AI.
This is the question from me, just from your talk. Yani, what is the best?
Being friend of your child, especially while they are entering the adulthood phase, teenagers. When they are your friends, they will tell you, they will discuss with you, they will open their hearts to you. Being a very strict parent is number one, let's say, driving force to. So I think the key is being the friend.
Okay. This is
Okay, thank you very much. I want to have a question to Dr. Possible. Do you think that in the near future that we will have lifestyle clinic with multidisciplinary team in our PHC and hospital? Is it the vision of the leader or stakeholder to have lifestyle clinic, inshallah?
Thank you, Dr. Ahmed, for this question. Actually, we're working now to starting the program of the preventive medicine. And in primary health care, depending on the lifestyle medicine, our next step, inshallah, to have the lifestyle medicine clinic. And we also, for the secondary care, like now we starting to opening the diabetic food center. We will have the first clinic for lifestyle medicine in King Khalid Hospital, inshallah, nearly.
Okay. I break the rule of the conference because usually we receive it by. This is the last question.
لا، هو النقاش اجمل من الرابط. انا الفكره بناقش فيها الدكتور عبد الرحمن والدكتور شاري. في فكره اننا انا عندي اعتقاد بانه عمل سكرينينج الاكتشاف المبكر في الموديل اوف كير هذا اختيار، واحيانا اذا ما اتبعه تدخل وتدريب وتوعيه وتغيير لايف ستايل عند المريض يكون هو مجرد اضافه مريض بس دخلناه مبكر في السيستم، ما كان يدري واكتشفناه وصار يدري. وبالتالي احنا حنطلع بارقام كبيره جدا لناس احنا اكتشفناهم ولا ادري قديش نقدر نستوعبهم بخدمات يعني كواليتي عاليه. احيانا افكر اقول لو ان الموارد عندنا قليله نسبيا خلينا نشتغل على مش اكتشاف الحالات، اكتشاف السلوكيات، وناخذ ال7 أعمدة للنمط المعيشي ونشوف ايش اخبارها ايش اللي حاصل في السلوك في المجتمع، اكثر من اني اكتشف حاله عن حاله. مثلا ايش اخبار السهر في المجتمع، ايش اخبار المشي في المجتمع، ايش اخبار الصيام المتقطع او عدم الاكل بين الوجبات كسلوك له علاقه بالنمط المعيشي، ايش اخبار النوم وهكذا. فهل تتفقوا معي انه اكتشاف السلوكيات وادارتها قد يكون واعد وقليل الموارد مقارنة باكتشاف النزول والميدان والفحوص والتحاليل والسلسلة واللوجيستكس والتفاصيل هذه؟ يا ريت نفكر في الموضوع ده، لأنه حائل ممكن يكون نموذج شوية مختلف ومو بالضرورة يعني أبغى أقول إنه الوزارة أعطتنا جايد لاينز أكيد، لكن نقدر نشتغل شيء خاص بحائل. شكرا.
ممكن أعلق بس تعليق بسيط. لو تفتكروا في أيام الكوفيد 19 كلنا عندنا توكلنا في جوالاتنا، حتى لما بدأت المدرسة قالوا إنه لازم الأطفال اللي هم فوق 12 سنة اللي أخذوا التطعيم عشان يدخلوا لازم يكون معهم الجوال وعليه إنه هم أخذوا التطعيم وكده. لما تيجي تحس يعني you came on panic بيسألك أسئلة، فممكن يكون في زي كده تطبيق اللي هي الأسئلة اللي لها علاقة باللايف ستايل. في النهاية بيكون التطبيق أو يعمل له زي ريفيرنج سيستم أو يرسل زي نوت أو ألارم للهيلث كير أوثوريتيز إنه we have a potential case، إنه ممكن شخص وساعتها ينادوه مثلا يعملوا له further investigations أو كده. This is one of the ideas of using AI for prevention, let's say.
أنا اسمح لي دكتور يوسف. أول شيء دكتور صالح، جميل الفكرة إنه نبدأ نشتغل على موضوع مو بس الديزيز، نشتغل على الباد نسميه لايف ستايل مثلا. أنا أدعو الجميع يعني بعد العصر تشرفونا بالبوث في نموذج الرعاية الصحية. يقدم شيء سميناه السلم الصحي على ما يقارب من كل المدربين الصحيين للخدمات اللي يقدمونها في المناطق الصحية، سواء من حساب النشاط البدني كسكرينينج، سموكينج، الدايتيشن، وبرضه لما يجي يسوون مع نفس الهيلث كوتش راح ياخذ معهم حتى موضوع سليب، ويكمل كل السكس بيلرز معنا ويعطيه التقييم النهائي. بعدها يكون فيه زي ما تقول معاهدة أو إقرار من نفس البيشنت إنه أنا راح أحسن حياتي بناء على النمط الصحي الفلاني اللي عندي فيه السلوك غير جيد. فتشرفونا طال عمركم، حياكم الله.
شكرا. يعني ملاحظة مهمة دكتور. But يعني I'd like to say that we are already doing that through different projects. For example, population assessment, we set with that we can use to implement anti-lifestyle. I think that your point is really taken in consideration already. Thank you. Thank you.
Thank you so much. We reached the end of our session. Thank you for excellent speaker and also for
speakers for the informative presentation and discussion. Thank you, Dr. Najat. Now, Dr. Ahmed Rashdan will join us. To honoring our moderator, Dr. Yusuf Jarallah. Thank you, Doctor. Allah Hafiz. Thank you so much, our moderators, speakers, and audience. We hope that you benefited and enjoy in our first day of the conference. This is the end of the day. See you tomorrow, inshallah.